Hi everyone, welcome back to the final video of this week topics. And in this video, we are going to discuss on the management of major depressive disorder. So here is the case that we are going to use to discuss the pharmacotherapy management of major depressive disorder. Mr. K is a 48 years old, presented to the clinic for poor sleep with body ache and claimed that had not been able to sleep as before for the past 2 months. He lost his appetite, which is a loss of about 2 kilograms. He sensed that his wife and children were going ignoring him and felt rather useless. He felt sad and most of the time and had little energy for even the usual day-to-day activities, which caused him no longer interested in work and leisure activities, but nevertheless forced himself to continue working because he needed that money. However, he found it hard to focus and could not work as well as before. He also avoided social activities with his friends and family members. He had no past history of psychiatric problems. Physical examination did not reveal any abnormalities. He was diagnosed as major depressive disorder with insomnia. This slide shows the differences between depression and mania or hypomania. So depressions or low mood can be stated in this red color one here. Meanwhile, mania or hypomania or known as high mood in this green color here. So in this video, I would like to emphasize more on the major depressive disorder. So based on DSM-5, to diagnose a patient has this major depressive disorder, they may come or experience any 5 or more symptoms as stated in this box. So at least must experience depressed in the mood or anhedonia symptoms or loss of any interest for at least 2 weeks. This is because of cause of distress or impairment in social, occupational, or other important areas of functioning. So the major 5 symptoms are known as CPGs, as shown in these tables, is shown as insomnia or hypersomnia nearly every day due to the sleep changes, shows diminish of any interest or pleasure in all or almost all the activities or known as anhedonia, feel worthless or excessive or inappropriate guilt nearly every day, defined as depressed mood most of the days, feel sad, empty, hopeless, lack of energy, fatigue almost all the day, nearly every day, diminished ability to think or concentrate or indecisiveness nearly every day, significant in weight loss when not dieting, or weight gain due to decrease or increase in appetite in nearly every day, psychomotor changes, especially agitation or retardation nearly every day, recurrent thought of death, not just fear of dying, might be recurrent suicidal ideation without a specific plan, or suicide attempt or a specific plan for committing suicide. So if this patient has 5 or more signs of symptoms, doctor might want to diagnose this patient as MDD. So the general principles of major depressive disorder treatments are to relieve the symptoms, to reduce the morbidity and disability, and to limit the risk of self-harm and fatality. So the treatment of major depressive disorder can be further divided into 3 phases as shown in this diagram. So the first phase is the acute phase, which shows less than 12 weeks, continuation phase, and maintenance phase. In the acute phase, our target is to achieve the or period aiming to achieve the remissions. So meanwhile, the maintenance phase is period to prevent any relapse or prevent any recurrence and development of chronicity. We can say the patient has a good response is more than 50% in reduction in depressive symptoms and at least a moderate degree of global improvement. We can say the patient has no response to the treatment if they cannot achieve more than 25% decrease in baseline symptom severity. Meanwhile, partial response is between the 25 to 50% decrease in baseline symptom severity. Remission is the absence of any sign or any symptom in the current episode of depression and restoration of the function to the normal healthy lifestyle. Meanwhile, relapse is the return of symptom of the current episode within 6 months following the remissions. We can say that patient has fully recovered or recovery when an individual is fully functional to the normal patient, to the normal, and has returned to pre-morbid functioning. Meanwhile, recurrence is a new episode of depression after the recovery. So the modalities of the treatment in major depressive disorders include the pharmacotherapy as well as psychotherapy and psychosocial intervention. However, in the pharmacotherapy of major depressive disorder, it took about 3 months, which is more than 12 weeks, to achieve the full response or known as remissions. So why this thing happened, you might want to recap back to the Madam Marciana lecture notes on the potential compensatory changes in gene transcriptions to discuss the underlying mechanism why this drug took this quite prolonged time of treatment. The choice of antidepressant medication will depend on various factors, including the efficacy, tolerability, patient profiles, and comorbidities of the patients, concomitant medications that the patients are ongoing, drug-drug interaction that might be happen, beside the cost, availability, as well as patient preference. So you might want to look on this algorithm to choose of the pharmacotherapy for major depressive disorders. Once the patient has been diagnosed of MDD, you might want to start the second generation antidepressants such as selective serotonin reuptake inhibitors or known as SSRI, serotonin and noradrenaline reuptake inhibitor or SNRI, noradrenergic and specific serotonergic antidepressant NASSA, noradrenaline and dopamine reuptake inhibitor NDRI, multimodal serotonin modulator as well as melatonergic agonist and serotonergic antagonist. So you might want to take into account the efficacy and side effect profile of these most second generation antidepressants. So if the patient has responded well, and achieve the remissions, you might want to continue the maintenance phase treatment about 6 to 9 months after onset of the remissions. Okay, for those who are failed to the current suggested treatment, current therapy, so you might want to consider to change the medication of any second generation of antidepressants. Based on the recent clinical study and network meta-analysis, clinical practice guideline recommended that one of the 6 group of second generation antidepressants should be prescribed in moderate to severe major depressive disorders, including either in this group of agent SSRI, SNRI, NASSA, melatonergic agonist and serotonergic antagonist or known as MASA, multimodal serotonin modulator or noradrenaline dopamine reuptake inhibitors. So, as you can see in this slide, the font of drugs that being bold, such as escitalopram, paroxetine, venlafaxine, mirtazapine, agomelatine, vortioxetine, as well as amitriptyline, were more effective than compared to the other antidepressant drugs. Whereas the light brown font here, such as fluoxetine, fluvoxamine, were the least effective drugs. In terms of acceptability, the drugs that have denoted single star show more tolerable than other antidepressants, whereas double star such as TCA, group, MAOI group, duloxetine as well as venlafaxine had the highest dropout rates. Why this agent has high dropout rate, especially the tricyclic or tetracyclic antidepressants and MAOI, or known as monoamine oxidase inhibitors, because this agent block numerous receptors. It block the reuptake of norepinephrine, as well as at the same time it antagonizes the effect of histaminic H1 receptors, alpha-1 adrenergic receptors, as well as muscarinic cholinergic receptors. It's not only that, these antagonist effects in a wide range of receptors cause the TCA as well as MAOI have poor tolerability due to various side effects, such as when it blocks the H1 receptors, it can cause sedation and weight gain. When it blocks to an alpha-1 receptors, it causes the orthostatic hypotension to the patient as well as dizziness to the patient. This drug also has the anticholinergic effects, which shown as constipation, dry mouth, blurred vision, as well as urinary retention. Meanwhile, the most common issues that we want to avoid is with the MAOI, which is the tyramine interactions. So you might want to recap back with Puan Maziana lecture note to further explanations, which will lead to the hypertensive crisis. So hypertensive crisis is defined as having diastolic blood pressure more than 120 mm per mercury, which is the normal range is 80 to 85 mm per mercury, which will lead to occipital headache and may radiate the frontally, palpitations, as well as dilate pupil or photophobia and tachycardia or bradycardia that can be associated with constricting of chest pain. SSRI, or selective serotonin reuptake inhibitor, as mentioned before, are generally better tolerated compared to other antidepressants. The most common side effects that are associated with SSRI are nausea, vomiting, and insomnia due to stimulation of serotonin in hypothalamus and brainstem, and also the diarrhea due to stimulation of serotonin and serotonin 3 and serotonin 4 receptor in the gastrointestine. However, excessive of serotonin in the synaptic cleft may cause serotonin syndrome such as high fever, or known as hyperthermia, shivering, confusion, agitation, incoordination, and tremor, as well as rhabdomyolysis in extremely severe cases. However, this drug cannot be used in combination with any MAOI or monoamine oxidase inhibitor, which can cause fatal when taken together. If you notice that SNRI, or serotonin and noradrenaline reuptake inhibitor, have similar side effects compared as well as SSRI. But not only that, it also has associated with other side effects due to reflex of noradrenergic activity, including the hypertension due to elevation of blood pressure, increase the heart rate and pulse rate. Not only that, blurred vision due to dilated pupils, as well as dry mouth and insomnia. Based on the American Psychiatry Association guideline, as well as our Malaysian Ministry of Health guideline, treatment for major depressive disorder with the features of anxiety, agitation, or insomnia, you might want to suggest doctor to add benzodiazepine or non-benzodiazepine hypnotics such as zolpidem and ensopiclone. So this group of drugs can be used as adjunct therapy to the current antidepressive medications to treat the anxiety, agitation, or insomnia features. So bear in mind that Z drugs only can be used to treat the insomnia but not the anxiety and agitation due to the pharmacological effect that they bind to selective GABA receptors. So you might want to recap back to my previous lecture note to further explanations. However, bear in mind, this group of drugs cannot be used more than 2 to 4 weeks to avoid any risk of dependency of abuse of these drugs. So in contrast of that, in addition of that, this combination of the combination of antidepressant together with the Z drugs or benzodiazepine will cause more severe side effects such as drowsiness or sedations. Patients who are on the major depressive disorder with the psychotic features such as hallucinations, delusions, you might want to suggest doctor to add atypical antipsychotic to the treatment regime to prevent or to treat the psychotic features. So this drug can be used to maintain the antipsychotic effect until the psychotic symptoms can be resolved. Similar to these benzodiazepine and non-benzodiazepine, combination with this atypical antipsychotic with the current antidepressant can cause more side effects such as drowsiness and sedations. You might want to consult to the patients to take it at night or during non-working environments day. Alright, based on this case, the patient has insomnia since 2 months ago, which caused the sleep changes. Significant weight loss about 2 kilograms due to no appetite, depressed, fatigue or loss of energy nearly every day, diminished ability to think, to or concentrate or indecisiveness, show diminished interest or pleasure in all or almost all the activities. So you might want to suggest to the doctor to initiate any second generation of antidepressants, and beside that might add a benzodiazepine such as lorazepam for 2 weeks. So the aim of the pharmacotherapy for this patient is in the maintenance phase. So is to prevent the relapse as well as prevent the recurrence. The duration of maintenance phase treatment is between 6 to 9 months after the remission periods. However, we need to consider the maintenance treatment for 2 years or more if there is a high risk of relapse or high risk of recurrence, such as frequent or recurrent episodes, severe episodes such as psychosis, severe impairment or suicidality attempt, chronic episodes, or present of any comorbid psychiatric or other medical conditions, presence of residual symptoms, or difficult to treat the current episodes. Discontinuation of antidepressants or pharmacotherapy may be initiated by the doctor after the 2 years of the maintenance therapy or any side effects or plan to change of the medications. But bear in mind that patient may experience discomfort when discontinuation is not properly done. The more common discontinuation in SSRI include the Finnish acronym, which are the flu-like symptoms, insomnia, nausea, imbalance, sensory disturbance, as well as hyperarousal. The discontinuation symptoms are more closely associated with the half-life. The most common one is the drugs who has short half-life such as paroxetine as compared to the long half-life which less likely to be occur such as fluoxetine. Therefore, discontinuation of antidepressant should be gradually within weeks or even can up to months unless there is urgency to do it, such as intolerable to these side effects. Alright, that's all for this week lecture. I hope that you guys have better understanding in the management how to choose which drug for the treatment of psychosis, schizophrenia, as well as the depressive disorders. So have a good day, everyone. Good luck for the next semester and as well as the final exam.